Good afternoon, everyone, and thank you for joining us. We are thrilled to bring you UC Davis's fourth Big Ideas virtual event, a series of online events we are running weekly through early June. For those of you whom I haven't yet had the pleasure of meeting, my name is Mariel Hughes, Executive Director of Development and your contact for UC Davis. A lot has happened in Davis and Sacramento in the last couple months. I'm happy to tell you that UC Davis and our health system have been working relentlessly to combat COVID-19. Our heroic healthcare providers have been treating and saving patients, running clinical trials and testing new therapies, all while taking care of emergency cases. And now our medical center and clinics are phasing in a return to normal operations. Our veterinary hospital started a similar phased resumption of regular services earlier this month. As we look to resuming activities on campus when it is safe to do so, there are two key areas of focus: instruction for the fall quarter and overall operations. We are working with individual departments and professional schools to find ways to offer some in-person classes this fall, based, as always, on advice from public health experts. Until then, we are glad to have this opportunity to connect with you virtually. If you have any questions during this presentation, please type them in the Q&A section of your screen. We will also have a short poll at the end of the Q&A for you to fill out. Please take a minute to do so when it pops up. I think that's it for housekeeping. Let's get started.
Driven by curiosity, passion, and ambition, championed by a community of supporters and the philanthropy of donors, the top minds of UC Davis have embarked on journeys of discovery, forging their own paths with transformative projects that will push boundaries, inspire change for generations, and provide solutions to the most urgent and critical problems in California and the world. Join us for an all-new virtual event and exclusive insider's view as we explore the many ways UC Davis is outgrowing the expected and how our cutting-edge ideas of today will become the impactful realities of tomorrow. Ladies and gentlemen, please welcome UC Davis Chancellor, Gary May.
It's a pleasure to gather together here today, in the current sense of gathering, that is. Teleconnections like the one we're using right now were the stuff of science fiction just a few decades ago. What seemed like an impossibility then has become an everyday work tool today. Many of you might have adapted to this new normal by having a doctor's visit conducted remotely. Today, we're thrilled to share a big idea that is harnessing technologies like this to reshape healthcare. Healthy Aging in a Digital World brings together a diverse team to develop creative solutions that empower people to remain in their homes as they age and remain connected to their care teams via telemedicine. In fact, UC Davis has long been a pioneer in the field of telemedicine, with over 20 years of experience providing remote health service to Northern California and Nevada. With our expertise, Healthy Aging in a Digital World will allow for endless opportunities to bring the best care for everyone. Again, I am so glad you're here joining us today. I hope you come away as hopeful and inspired as I am.
Thank you, Chancellor May. The Healthy Aging in a Digital World initiative is uniting a team of experts to design, develop, and evaluate creative solutions to enhance a person's daily life. Now it's my pleasure to introduce the leaders of that team, our Big Ideas co-champions. Heather M. Young, Dean Emerita of the Betty Irene Moore School of Nursing, and Thomas S. Nesbitt, Emeritus Associate Vice Chancellor for Strategic Technologies and Alliances, are both presenting today. Dr. Young served as the founding dean of the Betty Irene Moore School of Nursing for a decade. She is a nurse leader, educator, scientist, and nationally recognized expert in gerontological nursing and rural healthcare. Dr. Nesbitt has worked closely with leaders throughout California in developing partnerships with regional hospitals, clinics, and centers to expand access to quality healthcare and create a statewide broadband telehealth network. Their vision is to use technology to provide a bridge between independent living and access to healthcare across a person's lifespan. I'm looking forward to hearing their expertise and the details of this exciting big idea with you. please help me in welcoming Doctors Heather Young and Tom Nesbitt.
Thank you, Mariel. I'm Heather Young, and I'd like to welcome you to our webinar today. I'm here with my co-champion, Dr. Tom Nesbitt. We wish we could have been with you in person, but we're so delighted that you could join us. Healthy Aging in a Digital World came together as a collaboration among a diverse group of scientists who are all interested in aging and its implications for the healthcare system and for our lives. We also share a curiosity about how technology can optimize health and social function as we age. Most of our ideas are about the future, and we found that with the coronavirus pandemic, that the future is here today. In this webinar, we want to illustrate to you how healthy aging in the digital world is positioned to respond and bring innovation to many of our contemporary challenges. I'm sure that your life has been affected in small ways and in big ways by the COVID-19 pandemic. In fact, this outbreak is changing our assumptions about many elements in our lives. How we live, maintain safety, get care, how we might use technologies to promote health and support our healthy behaviors, how we can access high-quality care through telehealth, how we can interact with our family, with our friends, with information in ways that are easy and natural, how we can design senior housing to assure safety, promote interaction, and access to vital services and supports. As I listen to the news today, these themes are top of mind in our communities. And I'm so pleased to be working on these issues with the person who's considered an international thought leader in telehealth. And we're lucky to have him here to describe to us how his futuristic thinking that actually dates back a few decades, as you will see, serves us well during the crisis today. I'd like to introduce my colleague, Tom Nesbitt.
Thank you, Heather. So at UC Davis, we've been thinking about how technology-enabled care can improve people's lives for a long time. In the early 90s, through a grant with the Sierra Health Foundation, we developed a telefield monitoring link with a county about 70 miles north of UC Davis. That link was designed to co-monitor women who were in labor in that rural county and give them access to perinatal nurse specialists and perinatologists at UC Davis Health. That allowed women to deliver locally in their own hospital, but have the expertise of our specialists if they were needed. But then in 2020, in March, as you all know, the COVID crisis hit. And because we had been so active in this area, we were very easily able to ramp up our telemedicine visits to the home. So what we were able to do is to replace in-person visits with televisits to people's homes. And that really increased dramatically. In fact, we're currently doing about 1,000 visits a day via telemedicine. That is about 50% of the volume. Now, our in-person volume is starting to come back up, but we're going to continue to do some of those televisits to people's homes because for some of those patients, they're getting a return visit for their diabetes or their high blood pressure or their heart failure. And for some of those patients, the concern that they have is going out into public and particularly going out into a healthcare facility. And therefore, being able to provide them care at home is reassuring to them and allows us to give them the care that they need. Those chronic conditions are quite common in this country because as our population ages, those kinds of conditions increase. There's probably roughly 120 million Americans with chronic conditions like these. And as our population continues to age, there's going to be more. And telemedicine allows us to see patients in their homes with those conditions and actually see them more frequently than we would if we were doing in-person visits. Now, there's a lot of other things that happen as our society ages, and Heather's going to talk about some of those right now.
Thank you, Tom. Another reality of our aging population is the growing need for community services and supports. Much of this happens at home, but it also happens in other types of settings, because most of us at some point are going to need some help with our activities of daily living or in managing our health. And because women live longer, we tend to need care for a longer period of time. Most people will receive some kind of skilled nursing facility care at some point in their lives. So these settings are important, and designing them thoughtfully is something that's really critical for all of us. But the vast majority of people want to live at home, and they want to live there throughout their lives. And this provides a really important opportunity for all of us to be thinking about what kinds of services and supports will enable that vision to happen. Chronic disease is something that happens to all of us, and it's something that occurs in our homes, where we live, where we play, where we work. And so managing chronic conditions involves lifestyle types of issues. It's what most chronic diseases have in common is that they relate back to lifestyle, how we eat, our physical activity, our connection with other people, and how well we follow the recommendations of our healthcare providers. And this is where technology comes in as of a potential help. I'm serving on the California State Master Plan Stakeholder Advisory Group. And in that process, we're thinking of the strategic plan for the future, just as many states across the country are for the aging population. And as part of that process, we've gone out to town halls and had a lot of listening sessions to hear from older adults what it is that they really want in their future. And an important area of goals and desires, I think, really are resonant to all of us across our lifespan. The first one that we hear commonly is, I want to choose where I live, and I want to have the help I need to be able to do so. This means the types of long-term services and supports and the types of family caregiver involvement and friends and neighbors who can help me to live where I want to be. The second is around wanting to live in an age-friendly community. This is the kind of community where transportation is easy, housing is affordable and available, the parks and recreation are there to support us, and there are opportunities for engagement and connection with other people. Third issue is I want to have good health as I age. This is about promoting health and preventing injuries, and also having good access to the types of services that will help me to stay healthy. And then finally, to be financially secure and safe as long as I live, thinking about income and employment and those kinds of issues. And technology will clearly be a part of creating that preferred future. And we're finding that older adults are the fastest growing group that are actually adopting and using technology. Across all types of media, getting on the computer, social media, connecting with others, and using their tablets and their smartphones to manage their own health conditions. This is going to mean that we're going to have to do some transformation to really meet the needs. It's not about tiny incremental changes. It's about transformation. And I want to talk a little bit about what that could look like. This slide about transformation is actually an old slide with a lot of new meanings today in the context of COVID-19. We realize more than ever that we need to move expertise to people where they are rather than moving people to the expertise. That we have to expand care to the homes and to communities. And any of you who've had a virtual visit during this time will know what that means. It's about getting the supports and the advice that you need, where you need it, when you need it. It's also about an entire network of carers. It's not just the healthcare professionals. It's about engaging and involving families, neighbors, friends, others who are there to support and help us as we age. We also want to see value for our care. We want to see that when we spend money, we get good outcomes from that, rather than just paying for care as it's given. And that's a real transformation. And then finally, technology, instead of being a supportive force, is actually a disruptive force that forces further changes. And a good example is the use of pulse oximetry. So during the COVID-19 pandemic, people might show up at an emergency room and have trouble breathing. And the question is, should they be admitted, or can they go home and monitor their health at home? Now we can send people home with a pulse oximeter that monitors their oxygen level in their blood and can signal if there's a deterioration and a need for more intensive services. So people can be at home comfortable with their friends and family until they need to have more acute care. And these are the kinds of possibilities with technology. Tom is going to be able to talk with you in more detail about a number of the different areas that we're exploring and thinking about.
Thanks, Heather. So using technology to improve people's health, really takes a very organized approach, validating the technologies and approaching it in a very thoughtful way. And what we've tried to do is to organize these technologies in a way that makes sense to people. This picture is from a article in the Journal of General Internal Medicine that Heather and I published a couple of years ago. And what this shows is some technologies that you either wear or you carry with you. Those would be like activity sensors, that measure your steps. Some of you probably are wearing a Fitbit right now, or you're carrying your phone that measures your steps. But there's also technologies that can measure your vital signs. There's technologies that can determine whether you're at risk for a fall that you wear. There's other technologies that are in the home. That would include your iPad or your computer where you video conference from. It would also include things like medication detectors or medication systems that allow medications to be dispensed at the right time or alert you that a medication's needed. There are also fall detectors. And then there's a group of technologies that are the kinds of things that allow you to have a meeting like this one, or have a Parkinson's support group, or an Alzheimer's caregiver support group, or even accessing medical information from a medical library. All of those things can be very valuable as people age and make them and provide them with better care and better health. But all that needs to be integrated in to your care team. So your care team can know what's going on with you and know what those vital signs are in your activity and those kinds of things. So I want to go through some of the technologies very quickly. So this slide shows a number of technologies that are available. Some are big, bulky patches. Some are little Band-Aid strips. Some are wristbands that go around your wrist. If you have an Apple Watch, it can measure a 1-lead ECG. But again, a lot of this is too bulky to have someone wear all the time and be comfortable with it. So one of the things that we are working on is trying to combine these technologies and make them smaller. This slide is actually a picture of what they call a tattoo, but it's really a sticker that sticks on. Some of this work was done by NASA, and it involves being able to measure your vital signs, being able to measure your heart rate, things like that, as well as your temperature and those kinds of things. And that, with a very small device like this, it doesn't bother people to wear this all the time. Now, in this picture, you're seeing someone doing a home telemedicine consult. And this is great. This is can be a very high quality visit. You can see and talk to your providers. But as you can see, this gentleman is wearing a blood pressure cuff. He has a pulse oximeter in front of him and some other devices. Wouldn't it be nice if he was wearing that little sticker and he didn't have to do all those things? He might have a ring that measures his blood pressure. And not only would the caregivers be able to see what his vital signs were doing right now, but they could also look back to what they were doing before he did the visit and even during the week, and could say something like, "We noticed that your heart rate was up a couple of times quite high last week and wondered how you felt during that. Did you feel any dizziness or chest pain during that?" So that's a very valuable thing to have. Now, medication optimization is a really important part of aging and living with chronic conditions, because as people age, as we said, they get chronic conditions, and with that comes medications. Older adults tend to be on a lot of medications, and it's important that they take those appropriately. There's a number of situations where people end up in the hospital because they either didn't take their medication or they took their medication wrong. So there are a number of devices out there. Some dispense the medication at the right time of day. Some are glowing pill caps that make a noise and alert you when it's time, and when you take your medication, they shut off. And there's even chips that go into pills. They're fully digestible chips that a couple of companies have developed, where it will send a signal to a device and go into your chart that says what time you took your medication and what dose you took. Now, I promise you those things are completely harmless. They're fully digestible, but we're looking at various ways to be able to monitor that people are taking their medications appropriately. Now, one of the things that we often talk about is how can we provide therapy into people's homes? Well, this is one form of therapy. This is physical therapy. And this actually comes out of a study in Italy. But being able to video conference with someone like a physical therapist and being able to have them instruct you in how you do your physical therapy exercises can be extremely helpful. Some of you have probably participated in exercise classes during this COVID crisis. Well, it's really the same thing, but having a one-on-one consult. And we've actually done some work to gamify some of this so it can be fun to do your physical therapy, and you get points when you do it correctly. And so this is the kinds of things that we're thinking about for putting into homes to make things like physical therapy fun and also make sure you get them done appropriately without having to leave your home. And finally, in terms of technology, I want to talk about care into the home with a number of devices. So part of this is making sure to coordinate devices. This is a picture of a home that would probably be more appropriate for someone who you're concerned about, either with memory problems or you're concerned about falls, a parent or a family member that you're concerned about, that with a home that's designed in the right way with the right kinds of devices, you could monitor whether or not someone's left the water on or the stove on, or whether they got up and opened the refrigerator, whether they're following their normal routine that day, and make sure that nothing is wrong. And we're actually working with developers and home builders to think about what the built environment looks like in the future for older adults that will help them age in place and not have to go into an institutionalized setting just because someone's worried that they might leave the stove on or something like that. So this is very important. But it's also important, as I said earlier, for this to be able to coordinate with your care team and to have the information go into your electronic health record so that you can review it, but also your care team can review it. And so this is a slide from a grant that Heather was the principal investigator on that was looking at diabetics. And it took patient-generated information about their activity, their diet, and other things, and it seamlessly put it into the electronic medical record. Now, you may think that's easy. It's actually not, and it was a big undertaking to do that. But we have perfected the ability to move information that's generated by a patient and have it become part of your MyChart or your patient portal so that your care team and you can look at that. And we can look at things like your activity went up and your blood sugar went down and help prescribe the right exercise program to keep your blood sugar in the right place. And this is really important. But as you know, there's a lot of complexities to your care and your care team and other things. And one of the things we're trying to do with Healthy Aging in the Digital World is to organize and capture all of these pieces of information, organize them in a way that's easily accessible by a care team, but also easily accessible by you. And we want to even take this to the next step. So if we're able to organize this information in the right way in your electronic health record, we can also take it to the next step. And that is using machine learning and artificial intelligence to do predictive analytics. So let's take a patient, for instance, that has a condition that requires a medication that lowers their ability to fight infections. So it interferes with their immunity. And we look at the computer goes out and looks at labs. They look at the conditions the person has, and then you're wearing one of those little stickers and your temperature goes up by 0.5 degree and your heart rate goes up a little bit. and your blood oxygenation goes down a little bit, and your respiratory rate goes up a little bit. But none of those things enough to alarm you because you don't even notice them. But the computer would predict that this person's at an 85% risk of coming down with pneumonia in the next 48 hours. And therefore, we could intervene and keep that person from having to be admitted to the hospital. This takes a team of experts with a lot of expertise in a lot of different areas. And we are so fortunate to be at the University of California, Davis, where we have all that expertise, where we can work together to solve these problems. And I'm going to turn it over to Heather to talk about this now.
I'm so proud to be an Aggie and to be part of this comprehensive university at the University of California, Davis. As Tom and I dream about the future, this all becomes possible because of the breadth of expertise and the depth of expertise across our campuses. We are really delighted to be able to bring together diverse scientists, people who think about these issues and can bring very different ways of thinking about the problem and thinking about the solution. Because the problems we aim to solve are complex, and we need that kind of thinking to be able to make a difference. We're well positioned at UC Davis to increase our impact. We have state-of-the-art facilities on the Sacramento campus at the Betty Irene Moore Hall and at the Digital Health Resource Center. In these facilities, we have simulation spaces, home simulation, healthcare simulation, as well as lab facilities so that we can actually develop, test, and validate some of our solutions. All of these ideas are all well and good, but they have to apply to real people. And they have to be tested in ways that people can use them. And that's what we can do in our facilities. We also have excellent educational and research resources on our campus, across the entire UC Davis campus. Our clinical education is state-of-the-art. And along with that, we have research centers and institutes that we can draw upon with their expertise, including the Family Caregiving Institute in the School of Nursing at UC Davis. We're also working with people in the community to advance these ideas, developers who are thinking about senior housing and how to improve communities. And what we're really focusing on in the near term is supporting our faculty. We want to be able to support our faculty with endowed professorships, and we're interested in funding pilot research so that we can advance our agenda in healthy aging in the digital world. We so appreciate the time you spend with us today and your support always, and we're really eager to hear from you. We want to hear your comments, your suggestions, and your questions. Thank you for joining us.
Thank you, Heather and Tom. That was a fascinating presentation. Before I move on to questions from the audience, there are a few that I was wondering. So Tom, this first question is for you. Does this mean that you can't see your doctor in person anymore?
Great question, and I'm glad you asked it. Absolutely not. I think, first of all, I like to think of this model of care as a supplement to a large degree rather than a substitute. So, you know, we're limited to sight and sound as well as data that comes off these wearables, but there will be times that you need to come in and see your clinical team because you're going to need some more examination, you may need laboratory work, you may need an x-ray. And I know earlier in the presentation I said that, you know, some people feel uncomfortable coming into a health setting during this time, but I want to remind people and reassure people that, you know, if you need care, particularly acute care, you need to go in and be seen even during this time, because our clinics and hospital are a very safe place to do that. But as I said, this is part of an overall care model that includes some in-person care, but a lot of care that will be done remotely, and it will limit the number of times that you need to come in, and hopefully the goal is to keep people healthy so they don't need care.
Great, thank you, Tom. Heather, the next question is for you. How do family caregivers fit within this initiative?
Thanks, Muriel. That's a great question. All of the resources that we've been talking about are important for the person who's older, but also for the caregiver to connect with that person. So for example, a caregiver may live at a distance and not be able to see their parents or see their uncle or aunt, and would like to be able to communicate with them. So having technologies where you can actually communicate verbally and see one another, and also sometimes have the data so that if you have information about someone's activity during the day and some of the times when they may be a little bit less active, that might be a good time for a caregiver to give a phone call and to check in and to see how their person is. So I think it's really important to think of all of this at the unit level, which is the family or the care network, and that these technologies can provide us with information and ability to share important data among all of us as we navigate care and life.
Mm-hmm. Great. Thank you, Heather. Tom, this question is for you. Many parts of the US do not have access to the internet. Who in the medical aging community is advocating internet access as critical to healthcare?
Well, I think there's a lot of people advocating for that. There are, particularly for healthcare needs. There's earlier on, you mentioned in the introduction working on a project that was the California Telehealth Network. That was an FCC-funded project to develop, to essentially address the digital divide to rural and underserved areas. And so we were able to get a number of clinics and hospitals in remote areas connected. But that still doesn't address the issue of getting to the home in some of those areas. I think particularly with this recent crisis that we faced, there is a tremendous amount of interest, and there's a lot of talk by our policymakers about addressing the digital divide for healthcare, as well as for commercial reasons. That it's a big part of our economy now. So many people are discussing that, and the discussions have really gotten more intense as more telehealth has been being done during this COVID crisis. So again, there are places that will be later to get it, but that's improving dramatically. And then with some technologies like 5G that are coming out, that will make it less necessary for people to have individual connections into their home to do this kind of care.
Great, thanks, Tom. Heather, I'm going to direct the next question to you. These technologies look very promising. What do you see as the greatest constraints towards getting these implemented more widely? Are there issues around more current regulations, the lack of broadband access, insurance reimbursement policies, et cetera?
So those are all really important issues, Mariel, and part of what we're hoping to do in our group is to demonstrate the efficacy and the usefulness of these technologies, which in turn, that research can inform policy and can inform reimbursement ideas. So it's really critical that we do that work. The other big barrier, I think, is around making it really user-friendly for older adults and their families. And it's, none of us want to walk around with a whole lot of gadgets attached to us, with data that's not interpretable and useful. And as Tom said, and as he was talking about bringing this all together, all of these disparate sources of data need to be integrated in a way that turns into information that's useful for action and for decision making, either for the person themselves or for the people in their care team. And that's really another aspect of our work within the initiative, is to do that integration and to make it user-friendly so that older adults, it's intuitive to use, and it's not something that is a big barrier in terms of being able to adopt.
Could
Absolutely.
do you mind if I also respond a little bit about the policy issues?
Mm-hmm.
During this time, once this COVID crisis hit, there was the CMS and Medicare provided a number of waivers so that reimbursement could occur for telemedicine to the home in urban areas, which hadn't been the case prior to this. there's a lot of examination on the policy, in the policy arena right now, to look at whether or not some of these waivers should continue so that reimbursement can happen, as well as taking away some of the barriers that have been there in the past. And so I think this will result in probably more access to these kinds of care and allowing clinicians to be reimbursed.
Mm-hmm. Thank you for adding that. That's super helpful. Heather, I'm going to ask this next question to you. Many people have security concerns about how their data is used. Do you think that COVID-19 has increased people's willingness to give up some of their privacy concerns in favor of using more technology to get care and assistance remotely?
So I think it's really important to know, Mariel, that privacy and security are always a major issue for health systems, and that in even designing these opportunities for patients and families to engage, that it's within the context of being HIPAA compliant and making sure that we have those privacy protections so that people don't have to give up their privacy to do that. So it's a matter of designing within the context of the protections that we have. And that's where the electronic health record comes in, because there are a lot of guidelines and regulations to make sure that that happens. So that's a really important piece of it. A lot of people have found, though, that it's not so much giving up the privacy, but it's actually sharing more of themselves and what they do in their lives that actually helps their healthcare go better. So in that study that Tom referred to earlier for improving health and diabetes, we found that the people in our study were so delighted to actually have their healthcare provider see their own efforts, that they could see that they'd been walking, they could see that they'd been eating more vegetables. And when they went into the clinic and they were able to see the results of their efforts, that their blood sugar had improved and their medication maybe changed, that was a partnership that really came to life because of the data. And so I don't see it so much as either or, but how do you make the most of the information we have and make it available in a way that's safe and secure?
Mm-hmm. Yeah, that's so important these days. I think that's on a lot of people's minds. So Tom, the next question I'm going to ask is for you. It's a question from a retired physician who spoke a little bit about during their training to be a doctor, the history and physical exam were a mainstay in making a diagnosis. The question is about UC Davis's School of Medicine and a new School of Medicine curriculum. How will this type of technology and care delivery impact how physicians are trained?
That's a great question, and I think earlier I tried to say that this is a supplement. So this will not take the place of a complete physical examination, and that's why there are telemedicine solutions that are you swipe your credit card and you see some provider that you've never seen before. That's probably not as high quality of care as if you have a clinician who's done an exam on you and knows you well, and that clinician then sees you over video a week later to see how you're doing. That's a much stronger kind of model of care in terms of quality. But it will require more training in technology, and I think we are beginning to incorporate that. So as I said earlier, we ramped up our video visits to the home to actually about 1,000 a day, and that happened across the UC system. The University of California Health systems do about 10,000 video visits a day now during this time period, which is many times what they were doing before. And one of the things we realized is if a clinician is meeting with a patient one-on-one, I mean, if you came into the clinic, you might have had a medical student or a nursing student or a resident who was there with you during that visit. And one of the things we've been able to do is to create a three-way visit so that a medical student could be part of a visit and learn how to do these kinds of models of care. That three-way visit, by the way, also allows a family member who may be a distance away to coming in to being part of that visit for an older parent or something like that. But we're definitely training more with technology-enabled models of care. Our neurology residents now routinely are involved with telestroke care to remote hospitals where we're about to get a transfer, and they're working with a attending to provide care over distance. And one of the things, I'll finish with, in terms of physical examination, is that as we develop certain kinds of technologies, again, it will not replace the physical exam that you get in an office, but there are some technologies that will help with that. We can, again, all of the vital sign things that we're talking about, pulse oximetry, we have telestethoscopes, we have, I have a device right here that will measure a single lead ECG, and I have this device right here, which is a pulse oximeter, that, if somebody's wearing that, and you can see what their oxygenation level is, and you can listen to their lungs remotely, you can do some of that exam. And we're spending more time with our students and our residents participating in these kinds of visits with us. But again, it's essential that our medical students and residents get the hands-on skills of physical examination prior to doing this kind of care.
Yeah, absolutely. That's so important for the training of the next generation of medical care providers. So, Tom, I'm going to actually ask a follow-up question. There's been a couple of questions about artificial intelligence and predictive analytics and how that works, both on the user side, but also on the physician or care technician side. How are these artificial intelligence technologies going to impact the skills and training needed by health providers?
Well, it adds members to the team. So we have, health informaticists that work with us that design these alerts. So imagine, you can't have just raw data flowing into a clinician. So in other words, a clinician can't simultaneously monitor 100 patients' heart rates, but you can develop tools like a dashboard that you can look at all your chronic disease patients with, in our heart failure clinic. Our heart failure clinicians can look at a dashboard every day for their patients being monitored at home, and they can look at who is doing well in terms of a number of metrics that an algorithm is set up to say, their weight hasn't gone up, their respiratory rate hasn't gone up, their activity level is good and normal, their pulse ox is normal, and they see green beside all those patients on a dashboard. I mean, this is what we're shooting for in the future. But there's some that are yellow, and if there's one that's red, they call them right away and say, you need to come in, we need to see you right now. I notice your weight's up, your pulse ox is not good, and your respiratory rate's up. So there's people with the care team that does that, but there's also alert systems. There's technology now that can even alert a clinician's cell phone to say, that if we build an algorithm that says this is a critical situation, if these 5 things happen, it can even call them and say this patient is having some issues, and the on-call person can say, hey, I'm noticing, did you have some kind of issue right now? Are you feeling okay? So those are from the provider side. And from the patient side, it's important for them to be able to see the same information. So they're looking at the same information, and they're seeing how they're doing. Something as simple as, you didn't get enough exercise today to keep your blood sugar down. We all hate that when we look at our Fitbit and it says we only did 5,000 steps, and you say, I know I did more than that. But, it's important that patients and clinicians get the information.
Yeah, and this way the patient has an active role to play in their own health. And that's
Yes.
the beauty of these technological devices.
Yes.
So Heather, the next question is for you. How can the aging population have access to more gerontologists as opposed to internal medicine doctors or generalists?
Mariel, that's a question after my own heart. I've spent most of my career worrying about that. I used to think we needed more and more specialists in geriatrics, and we spent a lot of time in the field trying to generate those experts. But about a decade ago, I came to the realization that we need to gerontologize everyone, which means that all people who are clinicians, whether you're nurses or doctors or pharmacists or social workers, or others, need to have some understanding of aging and the conditions around aging and the circumstances of older people. And so now we really emphasize getting that skill set and that understanding integrated across all of our curricula so that people will be prepared. Unless you're a labor and delivery nurse, you probably need to know something about older people, even if it's the grandparents of the new baby that you'll be visiting with. So we're really trying to see it as, because of the prevalence of aging in our society, and the fact that I really believe aging starts when you're born, and that aging across the lifespan is what we have to pay attention to. So the things that we do when we're in our 20s and 30s will set us up for being a healthy 90-year-old. And so having that perspective and making it part of our thinking is a really important direction.
Great, thanks, Heather. The next question is kind of up for grabs. We've actually had a few questions about that tattoo patch, if it's available and if it's waterproof, and just a little more information about that. That seemed to catch a lot of people's attention.
So it's not widely available yet, but so this was that came out of Science magazine. There was an article about that, and there's a number of them. If you look up the tattoo health stickers or health patches, you can find a number of these, and some of these are becoming commercially available. The ones that we're using right now for some of our studies are more like a Band-Aid that have the electronics in it. I haven't worked with a company that's producing exactly that kind, but the way I became aware of it, I have a colleague that I was working with who was one of the NASA team that was monitoring the space station, and she was the one who told me about that. But again, that there was an article about that in Science magazine, and I think some of those are becoming available, if not already. And the idea would be to make them waterproof. They do need to be, at least from what I'm aware, they do need to be changed out, maybe monthly or something like that. But again, it's going to get, the technology is getting smaller and less bulky all the time.
So Tom, as a follow-up, sorry, it's not a follow-up, but it's another question to you. What are the primary considerations around deciding whether a patient should be seen virtually or in person? Would that be decided jointly between insurance carriers and healthcare providers? How are those decisions made?
So we've dealt with this for the whole time we've been doing telemedicine, because even if we're seeing a patient in a primary care doctor's office, if one of our specialists is seeing a patient in a primary care doctor's office, in a remote rural area, which we've done that kind of telemedicine for, over 2 decades. We have tried to develop some protocols about what kinds of conditions are appropriate to be seen remotely, but what kinds of condition require in-person care because you need to do an evaluation. The same thing goes for visits to home. And really, what we always say to our clinicians is, do not compromise quality for convenience. If there's something that you say, I'm a little uncomfortable with that, I'd feel better if I could see you in the office. That's when we make the decision. It's jointly made by the clinician and the patient. There are, right now there's so much change going on in the payer world because they're supporting these visits almost across the board right now during this crisis. And as I said earlier, I believe that we'll see some big changes. And hopefully it'll be between the patient and the clinician to make that decision, and it won't be a barrier.
Tom, I think we lost you. Tom, are you
Am I
there?
back? Yeah.
Yeah, your voice is back, and now your picture is great.
Okay, something happened.
All
Okay,
right,
so
my
anyway,
next, yeah.
no, what I was saying is that the ideal situation, and certainly what I recommend when I talk to payers, is that these decisions need to be made between a clinician and their patient, and make a decision of how many in-person visits versus remote visits can be done appropriately and maintain quality.
Heather, the next question is for you. Would you share what other team members of healthcare you have working with you, such as social workers, physical therapists, and others?
Absolutely. So that's a great question. And as you know, aging is something that affects all parts of ourselves and all parts of our bodies and all of our systems. So having an interdisciplinary team is really vital. So among the health system, we have a variety of different people who take on normal health professional types of roles, and have those kinds of insights from social work, from a social services perspective, as well as from the traditional clinician perspectives. Health informaticists are really important. We've got collaborators in humanities and arts. There's some people in design who are working with us on things like wearable clothing that has wearables embedded so that it's more comfortable. So there are people with that kind of expertise. There are a large number of engineers and computer scientists who look at anything from the actual monitors and sensors to what's possible online and what's possible in terms of the computing and the artificial intelligence aspects. There are people who are interested in the ethics and the policy aspects of this work, and that's really vital as well. Psychology, we've got people from human development who understand cognition and how people think. So it's a very broad team. And as we do particular projects, we'll bring in the expertise that we need that will be relevant to that particular project.
Mm-hmm. Yeah, it's certainly a big team, very complex, and all working together. So the next question, I guess this is for either Heather or Tom, but let me present it to Heather first. We've had a few questions about how HADWA can fit within Aggie Square. As you know, Aggie Square is envisioned to have co-location of technology companies and academic partners, biomedical engineering, medical device development is certainly on the table. How do you envision partnering with Aggie Square?
So this was one of the most exciting things for us when we first started hearing about Aggie Square, because we saw immediate synergy. So the idea that we can work between academia and industry to look at potential products, do the validation and testing, and also give ideas to industry about what's needed from the perspective of consumers and clinicians. The other piece that excites me is the idea of students and the next generation. And we're very eager, and we have a number of students that are involved in our work. And for them to be able to work in that kind of a laboratory where there's a partnership between their academic learning and their research projects and the industry possibilities, not only does it develop their thinking and their ability to work across teams, but it also is a potential avenue for them for careers after they graduate. And whether you're a clinician or you're an engineer, many people do go into industry these days, and this is a perfect training opportunity. So we're really excited about that partnership.
Great, thanks so much, Heather. So we probably have time for one last question, but before I ask it, we will be launching a short poll. It's just got, I think, 4 questions, so it's going to pop up on your screen in a few seconds. If you could take the time to fill that out, that would be really helpful. So my next and final question will be directed at Tom. Tom, can you share kind of a future forward look at what's happening with healthy aging in a digital world? What sorts of new innovations and discoveries are you working on?
Sure. So Heather touched on a little bit of it in her last answer. One thing we're doing is we have a digital health resource center that we've set up that is really designed to work with Aggie Square, but to work with industry to essentially validate devices, to find out where the gaps are in the devices that are out there, and to make sure that we fill those gaps with the help of our College of Engineering and other innovators. So one of the things we're doing is taking a real deep dive into what are the technologies that are out there right now, which ones do we want to use, which ones do we want to study, and we're doing some studies. We're doing some studies with people with chronic obstructive pulmonary disease. We're doing some studies with heart failure patients. We're setting up studies in a number of different areas to look at these technologies and validate them. The other thing we're doing is as Heather mentioned, we're working with developers and home builders to talk about what the home of the future looks like for older adults, to really design sort of ideally, if we could design the home of the future to help people age in place. So there's a lot of work going on in that. And I'll finally say that there's been a lot of resources that have come forward recently around this COVID crisis to see how we can provide care remotely. And that's given us a big opportunity to do a number of investigations much quicker than we would have been able to do. But we really need to take it to the next step and to integrate it into people's normal health care.
Mm-hmm. Great. Thanks so much for sharing your vision. I know there were a few questions around that, so I'm glad you were able to answer and provide some specifics about where we're heading and, in the years and days to come. So I'll end the Q&A session now with a big thank you to Tom and Heather. This was great. And also thank you to the audience. We had a lot of wonderful questions from the audience, and I really appreciate all of you writing them. We did not get a chance to ask all of them, so we will be following up with you individually with answers to your questions if they didn't get asked during this webinar. If you were interested in learning more about healthy aging in a digital world, please feel free to contact Heather Young, Tom Nesbitt, or Lizzie Coyle. Their contact information is up on the screen and will also be shared in a follow-up email. We could not do all the great work we've spoken of today or do it so well without philanthropic support. With your partnership, UC Davis can have a positive impact on the fields we touch, on society, and on the planet. Although we couldn't gather today together in person, I want to express our gratitude to each of you for taking the time to connect with UC Davis. Our next event on the Center for Violence Prevention Research will be May 27th from noon to 1 p.m. Pacific Time. This webinar will focus on preventing violence in all its forms. Please make sure to register if you are interested. On behalf of the university, we hope you are staying healthy and safe. I look forward to connecting with you again. Thank you again, and take care.